Good morning. I would like to thank Professor Dhiman, Professor Amit for providing me this opportunity. So I'll be talking about refractory variceal bleed management strategies. Okay, so I think variceal bleed is a very common thing that you see in your day-to-day practice, and it's important to know what you need to do once you have failed in the first or second session of endoscopic therapy. Refractory variceal bleed, how do you define it? It's either because of failure to control the bleed or failure of secondary prophylaxis. So acute bleed that is within 5 days, within the first 5 days, or there is a death or need to modify the treatment due to one of the following criteria, which is hematemesis or NG aspirate more than 100 ml after 2 hours of starting the medical treatment or endoscopic intervention, development of a hypovolemic shock, or decrease in hemoglobin of 3 gram or more, and the failure of secondary prophylaxis, that is one episode of bleed after 5 days from a portal hypertensive source, which is clinically significant, or there is a rebleed which merits either hospital admission, blood transfusion, decrease in the hemoglobin more than 3, or death within a period of 6 weeks. This is how you define refractory variceal bleed. The management options for refractory variceal bleed includes either a temporary measure, which can be balloon tamponade or esophageal stent. It can be a definitive measure, which is usually transvenous in the form of decompressive tips or an obliterative BRTO. Surgical options used less often can be in the form of transection, shunts, or liver transplant. So coming first to the balloon tamponade, as you are familiar with this particular tube, this is a Singh-Sticken Beckenbauer tube. Here, the gastric balloon volume is 200 to 400 ml. This is different from the Minnesota tube, where the gastric balloon volume is more, that is 500 ml. Moreover, the number of ports here are 3. Here, the number of ports is 4, and this additional port is primarily for the esophageal aspiration. The third tube is a Linton Naculus tube. Here, the gastric balloon volume is further more, which is 600 ml. And again, here you have 3 ports. The 3 ports, here you don't have the esophageal balloon port. So what's the efficacy of balloon tamponade in treatment of bleeding gastric and esophageal varices? So as you see, the primary hemostasis, both the SB tube or a Linton tube, is around 90%. The permanent hemostasis, if you see, is less, that is not more than 50%. And there are complications of death as well. If you see the complication, aspiration pneumonia to the tune of around 10%. You have other complications as chest pain, nasal necrosis, or transient airway obstruction. So total complications turns out to be tune of around 30%. So this is again an old study, 1978, comparing the Linton tube with an SB tube. And what you find here for esophageal varices, SB tube is better than a Linton tube. However, for the gastric varix, SB tube doesn't work, and you just have Linton tube with you for this gastric varix. Moreover, they have in this particular study they talked about using traction while using the SB tube, and uniformly in all patients, without traction, the complications were less. So the conclusion was the SB tube without traction for bleeding esophageal varices, and Linton's tube with traction for bleeding gastric varix. Again, you can have complications. So this is one of the scary complications that you can have when you pull the gastric balloon up in the esophagus. So this is what the gastric balloon is. And you can have esophageal rupture because of SB tube. So these complications need to be thought of. The second option is an esophageal stent. Now we have metal stent. This is for uncontrolled variceal bleed. This is fully covered, made of nitinol, and has atraumatic edges and can be placed for a period of 14 days, unlike SB tube, which you need to deflate after a period of 24 hours. And it serves as a bridge for subsequent repeat EVL or TIPS. So as you can see, this is a stent. The width is 25 millimeter, length is 13.5 centimeter. So this has got a simple delivery device. The advantage of this particular stent is that it can be placed either without fluoroscopy or endoscopy. And once it is adequately placed, achieves a good tamponade. This particular metal stent, as you can see, after deployment, the lower end of the stent is at the level of G junction. So what do we have? What the evidence we have for this? You see these multiple studies for this particular esophageal stent. This is a systematic review having cases of 10 to 34, child B and C status. If you see the success of deployment, this is 90 to 100%. If you see the timing of stenting, it can be placed for 1 to 14 days. No major stent-related complications, bleeding controlled in the majority to the tune of 70 to 100%, and death from uncontrolled bleeding has been reported in 2 studies, which was high, 16% to 40%. So what are the distinct advantages of this particular stent? After deployment, patient can take orally. Physiological drainage of secretions can be kept for 2 weeks. As I mentioned, does not need a radiographic or even endoscopic assistance. And it's an alternative to TIPS when TIPS is contraindicated or there are complications of SB tube. Cannot be removed even by an agitated person. There are certain disadvantages. Rarely migration has been reported. Risk of necrosis, which is a concern with SB tube, rarely happens. But you cannot use this for gastric varix. So which to use? This is a balloon tamponade of metal stent for esophageal varices. This is an RCT, which clearly says that when you use a stent for a period of, and the survival they had studied at day 15, there was increased therapeutic success, increased control of bleed, less transfusion requirement, less adverse events, and decreased bleed at 15 days with the metal stent. So metal stents are clearly superior to balloon tamponade. However, there is no difference in 6-week survival. So the conclusion was esophageal stents have a greater efficacy with lower side effects than balloon tamponade in the control of esophageal variceal bleed and treatment failures. These findings favor the use of esophageal stents in patients with esophageal variceal bleed uncontrolled with medical and endoscopic treatment. So this slide is very, very important. The reason why I'm saying this is important because Beveno 7, 2022 Journal of Hepatology clearly says now in patients with acute variceal bleed, one should be doing a cross-sectional imaging, which was not earlier stressed upon. That is primarily a CT and MR, and the intention is to primarily pick up splanchnic vein thrombosis or HCC, and especially when you are managing a gastric varix, it helps to map the portosystemic collaterals in order to guide treatment. So very, very important, this Caldwell classification. What is important here to remember is what we have is type 1, whereas lesser curve gastric varix, type 2, fundal varix, and type 3, both the lesser curve and the gastric varix. 1B, 2B, and 3B stands for presence of gastrorenal shunt. This shunt is required to do a procedure known as BRTO. Otherwise, you can't do a BRTO. So coming to decompressive treatment, which is another option for patients with refractory bleed. So you just have to understand what this tip does. So as you can see, deploying a stent between the portal vein and the hepatic vein leads to reversal of flow here from the gastric varix, ultimately leading to the decreased pressure, portal pressure. And this is how the tips work. So this is a study done to evaluate tips in salvage therapy. They have studied 6-week and 1-week mortality. This is a retrospective study of 144 patients. Child C patients were 54. The treatment failure happened in 16%. In rest, it was successful. 6-week and 12-month mortality was 36% and 42%. Post-tips, ICU, pre-tips, ICU stay, MELD, and child status were independently assured with mortality at 6 weeks and 12 months. So this again is tips for gastric varix, the systematic review and meta-analysis of 6 studies, 3 RCT, 388 patients, tips 195, and endoscopic therapy in 193. What was shown in this particular study, the treatment failure is less with tips, rebleed is less with tips, and overall survival is better with tips. And the conclusion is a primary hemostasis to the tune of around 93%, which is very high. However, rebleeding does occur in 10 to 30%. 2 main drawbacks is poor primary shunt patency rate and post-placement hepatic encephalopathy, which can be to the tune of around 20%. So one word that one should be knowing is a preemptive tips. It's primarily with PTFE covered stents within 72 hours is indicated in patients bleeding from esophageal varices and type 1 and 2 gastroesophageal varices who meet any of the following criteria. What are these criteria? CTP-C less than 14, CTP-B more than 7 with active bleeding, and initial endoscopy or HVPG of greater than 20. Why preemptive tips? So preemptive tips primarily is designed because what has been shown that in patients who are treated with endoscopic therapy and then managed by a salvage tips have got a very high mortality. So that's the reason. So these are two studies which suggest the same, and the Beveno 7 consensus again mentions that if a patient is a candidate for preemptive tips, even the presence of ACLF or HCI admission does not preclude preemptive tips. So failure to control variceal bleed despite combined pharmacological and endoscopic therapy is best managed by salvage PTFE covered tips. However, it should not be done when child score is more than 14, MELD score more than 30, and lactate greater than 12, untilness the liver transplant is envisioned in the short term because a high mortality in these group of patients. So last option that is there for these patients is a BRTO. So it has been there since 1984. 85% of the patients have gastrorenal shunt compared to 15% in esophageal varices. For this, CT is mandatory, as I mentioned, to look for gastrorenal shunt. The obliteration is done with ethanolamine oleate or sodium tetradecyl sulfate. It has got the potential to increase the blood flow, and hence it is performed. It may also be performed in patients with deranged liver function and altered sensorium, unlike TIPS. Plug or coil-assisted obliteration are dual modalities, which is also known as PARTO. The complications that can happen, hemolysis, hemoglobinuria, pulmonary edema, and AKI. So just to understand this, you have a left renal vein. This is the gastrorenal shunt. What you are doing in this particular case, entering the renal vein either with the jugular or the femoral root, inflating a balloon here, and obliterating the gastric varix. So this is what you do. The advantage of this particular procedure is that you achieved complete obliteration of all the possible gastric variceal column, which is unlike with the other endoscopic therapies. So this again is a systematic review and meta-analysis of here you see a technical success very high, 96%, clinical success again 97%, complications to the tune of around 3% only. However, there is development of esophageal varices to around 30%, which is significant here. So how does BRTO compare with TIPS? So if you see the technique, primarily stent placement bypasses the liver and connecting portal and systemic territory. This is what TIPS does. Here it is occlusion of portosystemic shunt using sclerosing agent. It reduces the portal hypertension and the portal hypertension related complications and can be used in patients with portal vein thrombosis, while BRTO increases portal vein flow and may improve liver function. It does not increase HE. Disadvantage, however, in TIPS is may induce hepatic failure and aggravate cardiac myopathy, increased risk of post-procedure HE, as I mentioned, while BRTO increases portal hypertension, may aggravate esophageal varices, as I showed, to the tune of around 30%. However, it cannot be performed in case of portal vein thrombosis. Again, based on systematic review and meta-analysis, what you find, the technical success, initial hemostasis between these two techniques are similar. Rebleeding and HE significantly less common with BRTO. Procedure-related complications, however, more common with BRTO. Again, depends upon the expertise. I will just one slide about US guided coil and glue, because this modality is an effective modality. However, it has not been studied in patients with refractory bleeds. Therefore, I have just mentioned about it. You use coil and glue both in combination rather than using either alone. And coil acts as a scaffold to prevent the migration of the glue. That is what the coil does. And it has been shown in a systematic review and meta-analysis that it achieves obliteration. There's less recurrence and long-time rebleed is less compared to endoscopic glue that we commonly do. Finally, surgery is usually a last resort. You have esophageal devascularization procedure. We have shunt and a multiple shunts. I'm not going into this detail because of the paucity of time. So what we have that in a patient who presents with acute variceal bleed, if you have an esophageal after hemodynamic stabilization, you do an endoscopy, you have an esophageal variceal bleed, you do endoscopic variceal ligation. If the bleeding is controlled and the patient is at low risk, you can continue with secondary prophylaxis. If it's a high risk patient, as I mentioned earlier, HPPG more than 20, child score less than 14, child B with active bleed, preemptive tips may be done in this group. Variceal ligation with a persistent bleed, balloon tamponade or SEMS. Here you may prefer SEMS. And if the bleed is still uncontrolled, you do a rescue TIPS, BRTO, especially for gastric varix. And if the patient is still uncontrolled, you do a portocable shunt surgery. For a gastric variceal bleed, the first line is endoscopic coil and glue. Here you may have an EUS coil and glue also in place. If the patient still bleeds, again, balloon tamponade of SEMS, rescue SEMS, or portocable shunt surgery. If this is controlled, you can continue with the patient with repeated sessions of endoscopic therapy for endoscopic glue or EUS guided coil and glue. So balloon tamponade, SEMS, rescue TIPS, BRTO, and then ultimately, which only a few patients need, is shunt surgery. So to summarize, refractory variceal bleed, 10 to 20% of acute variceal bleed with a very high mortality. SEMS is more effective than balloon tamponade as a temporary measure. TIPS with PTFE stent is effective as definite rescue therapy and also as early therapy in a subset of patients, although long-term shunt patency is a concern. BRTO is as effective as TIPS and definite therapy for gastric varix, especially when TIPS is contraindicated. US-guided coil and glue therapy needs further studies in refractory bleed. Surgical shunts are effective as TIPS, especially in childs A and B with improved survival and reduced reintervention rates, but less commonly used. Thank you.